from Malawi. We have Daniel Ngugi from Kenya. We also have Mavuso, Eswatini. We have Ndlovu from Botswana. We have Mshaisa from University of Eswatini. I can see we are already up on the hour. It's already 3 o'clock. Feel all welcome to this session. I want to invite Lemmy from the Secretariat to start us off.
Yeah, thank you so much, Dr. Damaris. My name is Lemmy Mabuga. I work with ECSACONM Secretariat as a Senior Program Officer for the college. And I'm happy to join or to be with you in this exciting webinar on emergency and critical care nursing, saving lives in the golden hour. So first, can we go to the next slide, please? So I'm happy to invite all of you, and I'll move to the webinar norms. So the first one, all attendees should be on mute, but you can type in your questions or comments in the chat box. So feel free to type anything when any presenter is presenting so that you don't forget, because we'll go through the chat box. So this will be a 90-minute session. We are planning to have it as very exciting. The presenters have prepared themselves to give you new innovation, new knowledge and skills around the topic area. And let's be respectful of each other's opinion. Our hashtag for today is #ECSACONWebinar25. So to start, I would like to welcome Dr. Damaris Ochanda, who will be our moderator for today's webinar. Dr. Damaris is a senior lecturer in the School of Nursing, Midwifery, and Paramedical Sciences at Masinde Muliro University of Science and Technology in Kenya. She holds a bachelor's in science in nursing and Masters of Arts in Health Studies, Nursing Education, and she has a PhD. She's a doctor in public health. Dr. Ochanda is a registered nurse with extensive experience in clinical practice and academia spanning over 25 years. Throughout her career, she has demonstrated a strong commitment to advancing nursing and supporting professional growth of nursing through her contribution in nursing education. She's a member of ECSACONM and Sigma Theta Tau International Nursing Society. So Dr. Damaris Ochanda, you are welcome to proceed as a moderator for this session.
Thank you. Thank you so much, Lemmy, for that elaborate introduction. I welcome all the participants to this webinar. And our agenda for this session is as indicated here. We'll have opening remarks, and we'll also share the webinar objectives. We'll have an introduction of the panelists who will come and share with us critical insights in different topics that I'm going to share with you during the introduction. And then at the end, we will have a question and answer session, and we'll also have a vote of thanks. As indicated by Lemmy, I would like to encourage us to note down our questions or comments during the presentation by the different speakers, and then we can be able to address the questions at the end of the 3 presentations. So at this point, I'd like to welcome Lemmy to take us through opening remarks. Lemmy, please feel welcome.
Thank you so much. And on behalf of our executive, Madam President, Madam Glory Msibi, I would like to welcome you all to this very key topic on emergency and critical care nursing, saving lives in the golden hour. On behalf of ECSACONM, I warmly welcome you to this session on emergency and critical care nursing, saving lives in the golden hour. We all know that the golden hour is a critical time where prompt, skilled nursing and midwifery care can mean the difference between life and death. This session highlights our role as frontline responders, emphasizing timely, evidence-based interventions to save lives. We hope today's discussion inspire innovations, strengthen skills, and foster collaboration across our region to improve emergency and critical care outcomes. And with these opening remarks, I welcome you all, and please be attentive, listen, ask your question via chat box, but you also have time to raise your hand and ask your question given the guidance from our moderator. Thank you so much. Back to you, Doctor.
Okay. Thank you so much for those opening remarks. And as we have been told, the golden hour is very important. Our activities, our actions, our interventions at that particular point when we're interacting with the patient could mean either life or death. And during this session, we want to see what are the key areas that we need to look at, what is our role as critical care nurses, and what are the innovative approaches that we can be able to learn from. Now, we have three main objectives for this webinar, and these objectives will be covered by the three speakers. Our first objective is to equip the participants with the knowledge and skills to conduct rapid patient assessment and implement immediate life-saving interventions in emergency situations. Secondly, we hope to strengthen the capacity of the participants in advanced clinical management and critical care practices for patients with life-threatening conditions. And lastly, is to develop the participants' leadership, teamwork, and communication competencies that are necessary for effective performance in high-pressure healthcare environments. We have three experts who are going to speak to us today, and we are privileged to have them because they are experts in critical care, and we are going to see where their expertise lies and where we can actually be able to learn from them. Our first expert is Rutendo Tembo. She'll take us through rapid assessment and immediate life-saving intervention. Rutendo is an experienced critical care nurse, and she attained her BSc degree in critical care nursing from Birmingham City University. She has a strong foundation in providing high-quality patient care in critical situations. Her quality improvement expertise focuses on enhancing patient care and patient outcomes. She is the secretary for the Critical Care Nurses Association of Zambia, a nurse leader and mentor in guiding nurses achieve excellence in patient care. She has served in diverse settings, including government. She has served in diverse settings, including government and non-governmental settings, also in private practices. Rutendo Tembo, please feel welcome to this session. Secondly, we have Dr. Harris Haman. She is a neonatal nurse practitioner in the United States with decades of experience. She will take us through the topic Advanced Clinical Management and Critical Care Practices. She obtained her BSN from Pennsylvania State University and her master's and doctorate from Stony Brook University in New York. She has practiced clinically as well as in academia and has global health experience working with the Project Hope on capacity building in the neonatal units in Sierra Leone and Malawi. She has been able to participate in developing curriculum. She has taught. She has also developed bedside clinical education and preceptorship programs. She is a member of the Council of International Neonatal Nurses and has worked with them on developing curriculum and teaching in the orientation and university through development of those programs. She's also involved with Touching Lives Ministry, which is an NGO that provides medical education and resource needs to areas in Western Kenya. Dr. Harris Herman is also involved in various nursing organizations and is a member of the Penn State Medical School Global Health Advisory Board. Lastly, we are privileged to have Sabelo Mapenduka, who will take us through the last topic, building systems for sustainable integration. And she will specifically focus on leadership, teamwork, and communication in high pressure environments. Sabelo is an accomplished critical care nurse specialist, educator, and is also the current president of the Critical Care Nurses Association of Zambia. She has over 14 years of progressive experience in clinical practice, education, and health system strengthening. She is dedicated to advancing the quality and visibility of critical care nursing in sub-Saharan Africa. Sabelo holds a Master of Science in Professional Practice, specializing in adult critical care nursing from Birmingham City University in the UK, and serves as a nurse tutor at Lusaka College of Nursing and Midwifery, University Teaching Hospital. Under her leadership in the Critical Care Nurses Association of Zambia, she has been able to champion national training programs, policy engagement, and collaborative initiatives with the Ministry of Health, WHO, and academic partners. Her professional interests include post-ICU rehabilitation, critical care outreach, and integration of community-based care. Sabelo is passionate about building resilient health systems and empowering the next generation of African nurse leaders. You can see we have experts with the various areas of expertise, and we are privileged to have the three speakers. We welcome the three speakers to this session, and we look forward to an interactive session. We'll start with our first presenter, who is Rutendo Tembo. She will take us through rapid assessment and immediate life-saving interventions. Welcome, Rutendo.
Thank you very much, Dr. Otanda. Thank you for this opportunity. First of all, am I audible to everyone? Good afternoon.
I can hear you.
Yes,
right.
I can hear you.
Thank you very much. So this afternoon, for the next few minutes, we are looking at rapid assessment and immediate life-saving interventions. Let me start by saying that indeed critical care nurses and nurses that work in the critical care space require this skill to rapidly assess a deteriorating patient or a patient who's not doing so well, and therefore they need these skills in order to preserve life and reduce mortality in the critical care space. So when we talk about rapid assessment and immediate life-saving interventions, so what is rapid assessment? Just an overview, rapid assessment is basically a quick, systematic evaluation of the patient to identify and treat life-threatening conditions. I think the important term is to identify and treat. And this means that once you identify this life-threatening condition, you treat it there and then. You don't wait to go to the next step. Because like we've emphasized, this is a systematic, so meaning that it has to go step by step in a very objective and systematic way. So the whole goal of a rapid assessment is to recognize, respond, and stabilize within minutes. Our main topic is about saving lives in the golden hour. These precious 60 minutes are very important in saving the lives of that patient who has a life-threatening condition. So for a critical care nurse or emergency and trauma or any nurse that works in these high-pressure areas, early recognition and intervention are vital for survival. Above all, it is important for these nurses to activate the emergency and response system or backup so that help comes early. Many hands come on board to save this life that has changed condition. So what is involved in this rapid assessment then? So we look at the scene safety. What are we talking about scene safety? As we are approaching the patient, we need to make sure that the patient, the environment that the patient is in is safe. Basic things such as cables that are hanging loose, electric cables or adapters, we need to make sure that those are safe so that the people that are coming to help or you, the first responder, is safe to approach that patient. We need to make sure that there are no spillages because sometimes as you're in a hurry, depending on the type of flow that we have, sometimes that flow can be slippery. So as we are approaching that patient, we just need to make sure that it is indeed safe. And if not, we make it safe for everybody else that is going to come and render that help to the patient. The next important assessment is as you're approaching the patient, you make an initial impression of the patient. I think when you work in the clinical area, you are able to tell whether the patient is looking well because, as you may know, nurses are the ones that are with the patients 24 hours. And we're able to identify when the patient starts to look ill. And it is a very important skill for a nurse to actually identify and have that initial impression of the patient before you even do anything. Before you talk to the patient, you look at the patient and you do your assessment and you realize that this patient actually does look ill from the previous time that you were with the patient. And then you check for responsiveness. How do we check for responsiveness? You need to talk to the patient. If the patient was awake and suddenly they're no longer awake, then you know that there must be something wrong with this patient, especially when you tap, they're not responding to the voice, they're not responding to touch, they're not responding to pain. So you need to assess the responsiveness of the patient. So how do we do all these things? How do we assess for responsiveness? How do we approach this systematically? We use the ABCD approach. I'm sure this is not a novel approach to most of our listeners today. Most of us have used it in practice. And basically the ABCD approach is the airway, breathing, circulation, disability, and exposure. And in this presentation, we're going to see what it entails to follow the ABCD approach systematically. We can go to the next slide, please. So when we talk about airway, what are we talking about? So when you're assessing the airway, you want to check that the airway is patterned. What do we mean when we say that the airway is patterned? What we're trying to say is that, is this person able to breathe on their own? Are there any noises as the patient is breathing? Is it a silent breath? Is it a noisy breath? Are they struggling when they're breathing? You check for any obstruction. So how do you do that? How do you make that assessment? So you open the airway. Is the patient able to open the airway? If they are not, then you actually go down on the patient using maneuvers. You put your head against the patient's mouth to actually look, listen, and feel. I'm sure we know and are familiar with these terms, where you go down on the patient, you put your ear against the patient's mouth, and then you want to check, you are listening. If there's any breath that is coming, you are looking at the chest. You want to see if there's any rise and fall of the chest. You are feeling for any breath if the patient is actually breathing. And if they're breathing, well and good. Then you go to the next step in this systematic approach. But if they are not, what do you do then? So then you have to decide, can this airway be open? Why isn't this patient breathing? And does this patient need assistance? And what type of assistance does the patient need for them to breathe? And mind you, as we are talking about the golden hour, this assessment, the look, listen, and feel should be done within 10 seconds, not more than 10 seconds. It's a very quick assessment so that you are able to intervene in less than a minute. And in that less than a minute, you are able to do you do maneuvers such as the jaw thrust or the head tilt and chin lift. Or if the patient is able to open the air with a jaw thrust or head tilt, but they're not able to maintain that open airway, what do you do then? Then you go ahead and introduce airway adjuncts that we can see in the picture on my right, the oropharyngeal airways, or in this case, sometimes you can use a nasopharyngeal airway, depending on the presentation of the patient, if the oropharyngeal airway is contraindicated. And then you further on assess and see if the patient needs advanced airway adjuncts. Maybe when you put the oropharyngeal airway, the patient is still not able to maintain that airway, the saturations are not coming up, you need to put them on oxygen. So what do you do then? Then you go ahead and go to the advanced airway adjuncts, which is the laryngeal mask airway, where you need to go down the trachea, or you do an intubation. And if the patient is not taking any air at all, even after opening the airway, and you observe that there's actually an obstruction, an upper airway obstruction, then that patient might need a tracheostomy. When the airway is sorted, only after the airway is sorted, that's when you go now to breathing. So what is involved in breathing then? So for breathing, you want to assess the effectiveness or ineffectiveness of breathing, because we know that ineffective breathing is a life-threatening event and should be treated as respiratory arrest. So what do we assess for in breathing then? You need to check if the patient is breathing too fast, is the patient breathing too slow, because we know that if the patient is not breathing adequately, the oxygen intake is reduced, the patient will become hypoxic. So we assess the rate, we assess the depth as well. We need to check the rise and fall. We check for the saturations. How do we check for the saturations? This is the time when we start introducing gadgets such as the oxygen saturations. I know that with the coming for the post-COVID era, I think most healthcare facilities now have access to pulse oximeters, and we're able to assess for oxygen saturations using a pulse oximeter. And then we need to check if there's any increased respiratory effort. And maybe when you introduce oxygen to this patient, that respiratory effort is reduced. So you need to assess, is the patient using abdominal muscles? Is the patient using any extra accessory muscles as they are breathing? And is an advanced airway required? Because you've introduced oxygen and the patient is still not responding very well. If the patient has been intubated, does the patient need to be connected to a ventilator for a long time? Or do they require ventilation for a long period of time? Then you look for signs of respiratory distress or pneumothorax. I'm sure most of us are familiar with tension pneumothorax that can actually hinder the breathing for this patient. And the way we'll look down this presentation as we can, how we can actually correct pneumothorax. When we sort out the breathing, then we go to circulation. What do we look for in circulation then? So you assess the effectiveness of circulation by assessing the pulse, blood pressure, skin color, and temperature. These are basic interventions, or these are basic signs that we actually assess for, but very important, very cardinal in actually assessing the well-being of the patient. And it is important that nurses in the clinical area do not lose this skill, but rather they should hone it and become experts in doing the basics, because to save life, for nurses who spend more time with these patients, when we do the basics, we are supposed to do them very well, because that is the foundation of the assessment.
So what do we then assess for circulation? You look at the skin. Is the skin pale? Is the skin blue? And this could be an indication of poor perfusion, that the patient is not receiving enough fluids or patient is not receiving enough oxygen. You look for the capillary refill, and we know that the capillary refill should not be more than 2 seconds. And if it's more than 2 seconds, it means that there's inadequate perfusion. So we check for the temperature of the skin, actually, because you want to assess for shock if the patient is in shock, and then the temperature of the skin will be able to tell you the type of shock that this patient might be going through. You look for bleeding. Control that bleeding immediately. Depending on where the patient is bleeding from, this bleeding needs to be controlled so that we don't lose this patient. Most importantly, under circulation, establish IV access and begin fluid resuscitation if necessary. And in other cases, fluid resuscitation includes blood transfusion, especially in trauma situations where the patient is bleeding profusely. The patient might need 2 large bore cannulas that will require a massive transfusions and fluid resuscitations. Then you monitor the cardiac rhythm. When you call for help in your initial assessment, as you are calling for that assistance, the patient should have been hooked to the cardiac monitor so that you can assess the rhythm, because you don't want to run the risk of the patient going into cardiac arrest, because sometimes the cardiac arrest rhythms that this patient can go through are actually reversible, and you can shock them and actually save a life. Then we move on to disability. So under disability, what are we looking for then? So disability is performed as a rapid neurological assessment to determine the level of consciousness of the patient. There are several things that can actually cause a reduced level of consciousness, and it is important as you are doing your initial assessment, you need to have a baseline of how the patient is, how the level of consciousness is for that particular patient, so that the subsequent monitoring, you'll be able to know whether the patient is deteriorating, and this can tell you whether the interventions, the initial interventions that you're giving are actually working. So what do we look for then? You look for the pupillary response to light, and limb movement is a fast way to assess neurological function. And that is why it is important for all nurses to move with a torch, because it is the simplest way to assess disability for the patient. The other quick way to assess for neurological function is the AVPU, where you assess for alertness of the patient, whether the patient is responding only to verbal response, or the patient is responding to pain, or the patient is basically unresponsive. In that way, you'll be able to assess whether at what state the patient is in. And then a more elaborate assessment of neurological function that we are very familiar with is the Glasgow Coma Scale. Then we need to measure the blood sugar, and we need to manage any dysglycemia. This could be hypoglycemia or hyperglycemia. It is important to establish how the sugar levels for this patient is, because we know that hypoglycemia or hyperglycemia can actually distort the neurological function of the patient. And most importantly, we need to make sure that this patient who is not feeling well, the patient that we are assessing, is receiving high flow oxygenation to maintain perfusion. Then when we look at exposure, so what are we looking for then? Exposure is essential, especially in trauma or burns, fractures, which may be causes of the current problem that you're facing for that particular patient. So what are we looking for? We look for injuries or any rashes, deformities, or petechiae or bruising, because maybe the patient is having an anaphylactic reaction, and the patient has got rashes all over the body. You need to expose the patient and do a thorough assessment to make sure that whatever interventions that you're doing is the patient is actually responding. Then identify hidden injuries or medical alerts, because sometimes the patient can have some chest injuries that may be subtle, and only after you expose the patient can you actually identify those injuries. Then, even as we are exposing these patients, it is important to maintain privacy and prevent hypothermia. because we know that hypothermia is part of the lethal triad of death, especially in trauma, and we need to make sure that we maintain euthymia throughout our assessment and throughout our interventions as we are attending to these patients in the golden hour. It is important to evaluate the entire body, but we need to make sure that this patient is covered. Remember, even as the patient is going through this life-threatening condition, their dignity must still remain intact. We need to make sure that the patient is covered. We need to make sure that the patient is warm at all times. And we need to make sure that the patient is not subjected to unnecessary exposure, even as we are doing the survey. So this is basically the ABCD approach that we can use as a quick assessment as we are doing, as we are attending to these patients that are going through life-threatening conditions. And this assessment can actually be, you can go back, you do your assessment in airway and you realize that whatever interventions you've done, they are actually not working. You still go back and reassess until you correct that problem that you initially found in your initial assessment. When all those things are corrected and you reach up to exposure, you still have to go back and make sure that your ABCD, the patient is comfortable, the patient is responding well, and your interventions are actually giving you a positive response. That's when now you can go to your secondary survey. So what are some of the immediate life-saving interventions that you may actually conduct during your ABCD approach or during your rapid assessment? Like we already established, when you are at the airway, you need to make sure that your airway is clear and you are supplying oxygen. And what type of oxygen are we giving to these patients? Any patient with a life-threatening condition, patient who is not breathing well, patient with low oxygen saturations, we give high flow oxygen, preferably by a non-rebreather mask at a flow rate of 15 liters. And then sometimes when the patient is in a cardiac arrest, you assess the patient is not breathing, there is no pulse, there's no central pulse, you've checked your pulse in your carotid, there is no pulse, you commence your chest compressions there and then. And once the patient has been connected to a cardiac monitor and you have identified that this patient actually has got an arrhythmia, and this arrhythmia is shockable. And we know that the shockable arrhythmias in our algorithm is ventricular fibrillation and pulseless ventricular tachycardia. Then we defibrillate there and then, because chest compressions and defibrillations are not supposed to be delayed. Evidence has shown that early defibrillation and early start of chest compression that has actually saved countless lives. We need to make sure that we control the bleeding. How do we control the bleeding? This is by putting pressure. We do have tourniquet. If you don't have a tourniquet like our friends in the West, we can just get any material, a bandage, a gauze, a cloth, and tie that limb that is profusely bleeding. We need to, you can also perform a needle decompression for tension pneumothorax. And I know that some of us have seen it being done. Some of us have had the privilege to do it, where you actually just, when the patient presents with tension pneumothorax, patient is not breathing well, patient is almost going into cardiac arrest, and you've diagnosed it properly that this is tension pneumothorax, you just go ahead and insert a needle in the second intercostal space, mid-clavicular line, and you relieve that pressure, and the patient, you might have saved that life. And then fluid resuscitation is very important, especially when the patient is presenting with shock. We know that there are different kinds of shock. We have distributive shock, we have restrictive shock or obstructive shock, and it's important in shock to give fluids, but we give fluids according to the guidelines because we still don't want to over hydrate these patients. And then the important thing, obviously, sometimes you might need drug intervention. So you give emergency medications in order to correct that life-threatening indication. For example, if it's a cardiac arrest situations where you've done your chest compressions, you've done your fibrillations. At some point, you need to start introducing emergency medications such as amiodarone. You need to, if it's an arrhythmia, you need to give antiarrhythmic drugs. Like we've mentioned before, if it's hypovolemia, patient is in shock, the patient might need fluids, the patient might need inotropes to maintain that cardiac output for good perfusion of all the organs. Above all else, as you are doing your assessment, you have identified that the patient has got a life-threatening condition. The rapid activation of an emergency response team. I think it is important to have these teams in the hospital. I think all hospitals should have teams that are designated to respond to emergencies, because the emergencies doesn't only occur in the critical care area space, doesn't only occur in the emergency room, it can also occur in the ordinary wards. It can occur anywhere. And it is important for hospitals to establish teams that are dedicated to responding to these emergencies. Why should we have these teams? These are teams that have been trained, these are teams that have skills, and these are teams that understand and know how to respond to situations under pressure. So when we look at the principles of effective response then, so simultaneous assessment and intervention is very important. I think like we've emphasized is that as you are doing your assessment, you are intervening. So you do your assessment and you intervene, you give that solution to the problem that you've found. You don't wait to go to the next step. Prioritize life-threatening issues first. So this comes by identifying and understanding the physiology to know that if this airway is obstructed, I need to correct it first. You need reassessment is continuous. Like I mentioned earlier, you correct the situation, you go to the next step, but you keep an eye on what you've done before to make sure that the patient does not deteriorate. Teamwork and closed loop communication is very important. Like we always say, you do not work alone in emergency situations. You do not work alone in critical care and emergency situations. So it is important to involve a team, even at the beginning of the shift, at the beginning of the day, to make sure that work goes well and we save those patients. What do we mean when we say closed loop communication? So for closed loop communication, it is important that when I give an instruction, I ask someone to go and get an oral airway. The person I've asked should come back and tell me that the oral airway is in and the oral airway is ready to be placed. If the person has been tasked to actually insert the oral airway, the person should give feedback to say that the oral airway has been placed properly on the patient. When we are sending these tasks, during this closed loop communication, we use names. If we don't know the names, you can actually point at the person so that the person you are designating that task is known by you, the person who's sending, by the person who's receiving that communication, and also by the people that are around there, so that we don't have confusion. This actually prevents confusion. We've had situations where you are sending for something and you have 3 people go at the same time to go and get that one thing. So when you designate one person to say, bring IV fluids, or Irene, bring IV fluids, Irene should be able to come back and say, IV fluids is ready to be set up, so that we close off those communications. When we look at documentation and structured handover, sometimes we have a tendency to forget to document events that have happened on the ward or in any area or situation. So it is important that at the beginning, as we're assigning a task to the teams that we're working with, we assign a person who's going to do the documentation in any event that you need that you have an emergency. So it is important for documentation to be done properly, and you need to be tasked by a single person who can actually take responsibility of everything that is happening. This goes with handover. How do we hand over? How do you give a structured handover? We've had we have different ways of giving handover, but in emergency situation, the handover system that has been seen to be very effective and has reduced many errors, has actually protected the patients, is what we call the SBA type of communication. This is basically the situation, background, assessment, and recommendation. So as you are giving your handover, you give the situation of the event that has happened, you give background of the patient that you're handing over, you give an assessment, the assessment that you've actually done on the patient currently, and the recommendation or expectations that needs to be done on that patient.
You have 1 minute to summarize.
Thank you. So what do we take away from this then? So we say that early recognition saves lives, and application of the ABCD systematically and we should be able to act promptly. We need to ensure continuous monitoring and reassessment, and we need to work as a coordinated team. It is important to keep training, reflecting, and improving practice. And in doing this, together, we can make every second count. Thank you.
Thank you very much, Rutendo, for that awesome presentation on rapid assessment and immediate life-saving interventions. And we have been able to see how important it is for us to be able to conduct our assessment promptly, and also to be able to recognize early the problems that the patient has that we need to intervene in. Thank you so much. If you have any questions, please put them in the chat. And again, you can note them down. We'll have a question and answer session at the end after our third presentation. I want to take this opportunity to welcome our second presenter, Dr. Pamela Harris-Herman. Dr. Pamela will take us through a session on advanced clinical management and critical care practices in neonates. Welcome, Dr. Pamela.
Thank you very much for that welcome, and thank you all for allowing me to come and present to you. So these are the discussion points I'm going to go over this morning. We will talk a little bit about reviewing and monitoring neonates. Again, you'll find that a lot of the things that we talk about are very similar from presenter to presenter. And to me, that just really shows you how important those points are, that we still always discuss airway, breathing, circulation, fluid status, quality care initiatives. These are all things that are really themes throughout, regardless of your patient population. So a little bit about the background of this talk is that one thing that is important in looking at what we are doing when we deal with babies is the standardization of education. We standardize education for our NICU nurses, and we do that in a following manner, a couple of manners. We have programs that are recognized nationally, and we utilize those to educate the nurses. In doing so, that also allows us to give the nurses some autonomy and ability to proceed with steps that will help to save the lives of the babies, especially during that golden hour. And these allow us to develop protocols that not only impede medical, but also nursing. And I shouldn't say impede, but they affect in a positive way, so that we can move through steps in those early periods rapidly, succinctly, so that we can provide care. It also requires assessments of skills, and these are all things that we are doing one at a time. And and simultaneous. We all know that when we're looking at a baby, we are really assessing more than one thing at a time, and that's very important. And of course, quality care initiatives. What do we do to continue to provide this care at a high level? So one of the first things that we talk about in relationship to to the golden hour and to the monitoring is really observing the baby or your patient. This really, you can apply some of this to adults as well. We like to observe the babies every 15 minutes after birth until stable. And what am I looking for? I'm looking for the heart rate. I can check a pulse. I'm getting down there. I want to make sure that that baby's breathing. I can use pulse oximetry. In babies, another thing that's important to remember is temperature, especially in that first golden hour. If a baby, and I'll talk about this later, if a baby gets cold, it's going to rapidly and seriously affect the baby going forward. Other things we need to think about with babies are feeding and glucose, which are still almost kind of wrapped together. But feeding also gives us the ability to assess the baby's neurologic status, because if the baby isn't able to feed, that can tell us there might be an issue going on. Is the baby queuing to feed? So, a baby, doesn't have the same responses as an adult does. So these are things we need to look at in babies. Again, we, referenced this earlier, initial steps. Do we have things set up and ready? And this is very important. So no matter where you are, whether you are in casualty, whether you are in the NICU, you are in the delivery room, it is important to make sure that you have what you need. And that includes your equipment. What equipment are you going to need to potentially resuscitate this baby? Help. Do you have somebody who can assist you in this? Because you just can't do everything by yourself. So you need to make sure you have help. You need to make sure that the room is warm and does not have drafts, because again, this will severely affect the baby's temperature, and it's a safe environment. As my colleague talked about earlier, there's nothing on the floor to slip on. There's nothing that's going to stand in your way. You're not going to fall over. You can safely access the baby, the mom, and all the equipment you need without risk to yourself or to the baby. So in talking about infant resuscitation, at most deliveries, very few interventions are needed. Usually the babies come out and they cry, and we don't have to do a whole lot. But these are steps that should be initiated within the first few seconds and should be completed within 30 seconds of birth. So again, we're looking at this golden opportunity of time here. And one of them is to provide warmth. We need to make sure we provide a warm area for the baby. Again, our ABCs, we're opening the airway. Are there secretions? Dry and stimulate the baby. We're evaluating the respirations and the heart rate. And we're doing all this at the same time. While I'm trying and stimulating the baby, I'm looking at this baby's response. Can I feel a heart rate? Can I hear that? Is the baby crying and breathing? All this at one time is giving me a lot of information. If I need to, I can also go in and do some pulse oximetry, as well as provide supplemental oxygen. So again, we are all still doing our ABCs on these babies. And it's important to remember that the information that I'm giving you is based on things in the US, but it's based on all the guidelines, and I'll share those with you at the end, from the WHO to ENC, so your Essentials of Newborn Care. Each one of those programs takes off the other and just expands it and moves it into a little bit more advanced state. So one of the most important things in babies is ventilation. This is a little different from adults. A lot of times in adults, we get really focused on circulation. But in babies, when they are having a resuscitation need, it is usually associated with something with the lungs. So our main focus is to get those lungs moving again. So what baby's going to need assistance? Any baby that is experiencing moderate to severe distress, chest inpulling, noisy respirations, lack of respiration. They make that grunting noise, you'll see their little nostrils flare. And again, the inpulling of their chest, their heart rate may be dropping. And if you put a pulse oximeter on them, you may find that it's not, you're not getting a very high reading, or they may just simply be gasping for breath. So what are some of the things we are going to do next if we find the baby is not breathing well? We are going to institute positive pressure ventilation. And to do this, we need to remember a few things. There's a lot more to these steps, but I just wanted to give you some quick review points. One of them is to ensure that you have a proper seal of the mask and that covers the baby's mouth and nose completely. When you compress the bag, you want to make sure that the chest rises, but not excessively, but you want to look and make sure, is that chest moving? And you want to give an appropriate rate. And then remember, these rates will be different from adults because babies breathe a little bit faster than adults. So you want to make sure you are giving 40 to 60 breaths per minute, and you're giving a pressure of about 20 to 25 centimeters of water pressure. And with this bag, you can use it with or without oxygen. Either way is going to be potentially beneficial to the baby. So what happens if this isn't working? What can we do next? We have a little acronym or mnemonic that we call Mr. SOBA. And this gives us a list of things that we can do next to try and make sure that we get this baby breathing. Because remember, it is respirations that are going to be so important. Mask adjustment. Is it the right size? We can reposition the head. Suction the mouth and nose because it can be blocked by secretions. Maybe open the mouth a little bit, maybe increase the pressure, or we could also consider alternative airways. And this is an example of some alternative airways that are potential for the baby. Of course, we do have other things that we can use, such as oxygen and nasal CPAP. But should we get to a situation where the baby needs positive pressure ventilation and is not responding well, we can actually do in the first slide here, endotracheal intubation, where we slide an endotracheal tube into the baby's trachea. Or we can use something that is maybe a little easier to do and is something that could be done by nurses as well. It's called place an LMA. We mention them for adults, but they're also can be used in babies. And that just simply goes into the baby's esophagus, but effectively blocking it so that all the air that goes into the trachea and can expand the lungs. So how do we assess? Again, assessment. And a lot of these assessments are using our eyes. We don't always have to have all sorts of fancy equipment. We can do this with our eyes and our ears. So we want to look for the chest to rise. And every 30 seconds, we want to check and make sure that's still happening. Do we have rest sounds bilaterally? If we have a stethoscope, we can listen. Does the color change? Does this baby start to look pinker? And what is our heart rate? Is our heart rate increasing after 15 seconds and our chest is rising? Always remember, we need to make sure our chest is rising. So when would we consider stopping? When the baby's breathing spontaneously, when we have adequate heart rate, when the breathing is no longer labored, and when there's no apnea and no gasping. So one of the next steps might be if we have given adequate a positive pressure ventilation. So we have at least 30 seconds of positive pressure ventilation that inflates the lungs, i.e. we see the chest rise. And the heart rate still is low, it's less than 60, then we would consider giving chest compressions. However, always remember that if the chest is not moving with positive pressure ventilation, the lungs are not adequately inflated and chest compressions are not yet indicated. Again, with babies, ventilation is important. So you must continue to focus on achieving effective ventilation. The compression rate for babies is again different from adults. So you want to give 90 compressions per minute and the breathing rate is 30 breaths per minute. So this is going to give you a kind of a rapid cycle of 3 rapid compressions and 1 ventilation during each 2-second cycle. So that's 120 events per minute. And we do this by saying 1 and 2 and 3 and breathe. And this is where good communication is very important as well, because you are going to need to be saying 1 and 2 and 3 and breathe. And that needs to be out loud so that you are continually communicating with each other so that the person that's doing the ventilations knows when it's appropriate to step in. So again, we need to assess our effectiveness. Again, chest rising. It's very important to make sure that our chest is rising with each breath, because if not, we may need to adjust. And remember, our Mr. Soper rule is something we can utilize to adjust that. Is the airway secured? Do we need to consider putting a laryngeal mask in? Are you delivering this at an appropriate rate? Remember, it's going to be pretty fast, so you need to make sure this is appropriate. Make sure that your depth of compressions are 1/3 of the AP diameter of the chest, and make sure that you are also administering oxygen to this baby. So when am I going to consider stopping? After 60 seconds of chest compressions and ventilation, you need to briefly stop and check the heart rate. If the heart rate is 60 per minute or greater, you can stop compressions and you can continue with your positive pressure ventilation at a rate of 40 to 60 breaths per minute until the baby is spontaneously breathing. However, if the baby's heart rate remains less than 60 beats per minute, despite 60 seconds of effective ventilation and high quality coordinated chest compressions, remember, ventilation is so important. And when you start chest compressions, it is important that you have those coordinated. And this is one of those things that is very important to make sure that you practice as a team. You can practice this on mannequins to make sure that because it's so important that you can do this and you can work together as a team doing this. Medications. There are not a lot of medications that we give in babies like we do in adults that are coding. We use epinephrine, and I know some countries in Africa will use adrenaline, very similar medications. And we give this when the heart rate is less than 60 beats per minute, and there's been 30 seconds of effective assisted ventilation and another 60 seconds of coordinated compressions and airway. So again, you can see the importance of that ventilation and that coordination, that teamwork. We only use a concentration of 1 to 10,000, and this can be given IV or intraosseous. Fluid resuscitation can be given in babies as well. For this, we use some really simple things. We use normal saline. We give 10 mLs per kilo. And we use this when there's evidence of hypotension or poor perfusion. And again, that's an assessment that you're making by assessing the baby's color and their capillary refill. It can also be used while you're waiting for blood to arrive. We can give blood in babies when we suspect that there has been a known acute blood loss. This is something that would happen during a delivery, such as if there's been a placenta previa or an abruption, a placental abruption, or if there has been a cord accident where there's been a huge loss of blood. And we would give about 10 to 15 mLs per kilogram of whole blood or packed red blood cells. Thermoregulation is important, and I know that's kind of not part of our ABCs, but this is the next step. And it's not exactly the next step, but again, what I initially said was we need to make sure the area is warm. Babies lose heat through 4 main mechanisms, and that is conduction, convection, evaporation, and radiation. So the drafts in the room, the water that the baby's in, babies come out wet. So if the baby's cold and wet, if there's air currents, and if the baby is placed on something cold, are all going to cause the baby to lose heat. And signs of hypoglycemia of hypothermia can include hypoglycemia, respiratory distress, increased oxygen requirements, apnea. These are also signs, again, of respiratory distress. So you could have a baby who is cold who can effectively actually stop breathing on you because they are too cold. So it's important to remember to have the adequately warmed room, appropriate blankets. Again, we're always talking about drying and stimulating. So we need to make sure we have those dry blankets, that we have hats, that we are monitoring the temperature frequently. Even when we're doing resuscitation, somebody needs to take the effort to check on the baby's temperature. If we're using an overhead warmer, we need to have that warmer on servo control. And we need to make sure that we assure proper positioning of the temperature probe as well. And one of the best ways, once the baby is stable, is to place the baby skin to skin with the mom, and that will ensure adequate temperature regulation. Another factor to consider in babies is glucose. Hypoglycemia is a major issue in babies as well. So it's vital for cell energy and brain energy as what the glucose is needed for. And again, if you look at the signs of hypoglycemia, a lot of them are similar to things that we may see in a baby with respiratory distress. They can be apneic, they can be cyanotic. So again, we want to make sure that when we are doing this assessment as well, to make sure that why is the baby not breathing? Is the baby simply not breathing after birth, or has something else gone on? And the temperature and the glucose are factors we want to make sure that we are looking at as we are moving forward with the resuscitation. And remember, there are certain babies that are at higher risk for hypoglycemia, and that includes babies that are very small for gestational age or premature, babies that are large or infants of diabetic mothers, and any baby that has increased glucose utilization. So that is a baby that is in respiratory distress or is needing resuscitation efforts. And we can treat glucose with a simple treatment of dextrose of D10 water or 10% dextrose in water. And we simply give them 2 mLs per kilogram, and this can be given pretty rapidly. And then we need to make sure that we reassess it in the next within the next half an hour to make sure that the baby doesn't need more. Any baby that's needing resuscitation, we also need to keep in mind that they may need to have continuous IV fluids. And we usually start those at about 80 per kilo per day. And this should provide us with an adequate amount of glucose. Babies need about 4 to 6 milligrams per kilogram per minute of glucose, and running the IV at 80 per kilo per day will give you that and should help to deter any further evidence or issues associated with hypoglycemia. It's important to keep monitoring the glucose. Once you're done resuscitating the baby, monitoring glucose and monitoring temperature are important, because remember, a baby that is hypoglycemic and hypothermic can actually slip back into signs of respiratory distress as symptoms of those 2 factors. And another thing, if the baby is stable, the baby can be fed early. So post-resuscitation monitoring, I did touch on this a little bit. Again, continual assessment, heart rate, respiratory rate, and temperature. It's also important to make sure that we are assessing their glucose. Assess for hypoglycemia. Check a glucose. I like to check them every hour until they're stable. And stable for me in a baby that has been resuscitated is greater than 50 or greater than, I think it's 2.5 millimoles per deciliter. Make sure you're providing IV fluids. If you're having trouble getting an IV, as a nurse, you need to reach out to somebody who could potentially help you. Documentation, so important. Document what you've done and your handoff, so that people know what has transpired with this baby, so we can continue to provide appropriate care. Debriefing. If we've had an event that leads to resuscitation, we need to make sure that we discuss that situation, and these need to be positive, not accusatory. Talk about what went well and what you would change. So this will help with your continued process improvement practices. And don't forget to update the parents following an event such as this. Some quality care initiatives that are important. Again, standardizing the education on neonatal care. When you look at the factors from the WHO to the ENC to other neonatal resuscitation programs to the COIN orientation programs, they are all based on the same evidence-based practice. And that is important, that we maintain our skills and our initiatives within our nurseries so that our practices remain up to date on what is best for the babies. It's important that we continue to assess nursing skills of new staff and staff that are there, because sometimes we forget things if we don't use them all the time. Have continual education offerings for all nurses, especially dealing with events such as this that are such high acuity but may not occur often. We need to have, again, competency-based education and skills evaluation and reevaluation. Just because you've been a nurse for 5 or 6 or 10 years does not mean that you don't need to continue to have your skills updated and evaluated. research-based, evidence-based practice. And again, this applies for not only nursing, but for medicine as well. Our medical colleagues need to be doing the same. Identify gaps. Where have you discovered that you might need to have some work done? What is something you would change? And then develop quality improvement projects to address those gaps, and teamwork. Teamwork is so important. All of these steps that I've talked about and my colleagues have talked about require you to work together as a team. And that is how you will effectively care for babies and move things forward. And this is a list of suggested resources, and I have included the websites. So if you would like, you can go on the websites and look for things. These are what I have utilized in order to prepare this talk. And again, they are things that are associated with the World Health Organization and councils that are basically globally known. And I thank you so much for allowing me to speak with you and to share this information with you. Thank you.
Thank you. Thank you very much for that insightful session on advanced clinical management and critical care practices in neonates. We have been able to learn new information on how we can be able to attend to our neonates during the golden hour. Thank you very much, Dr. Harris Herman. We will now move to the third and last presentation. Our presenter is Sabelo Mapenduka, and she's going to take us through leadership, teamwork, and communication in high-pressure environments. And you'll realize that from our first and second presenter, there's a lot of emphasis on teamwork during this golden hour. So we want to hear from our presenter today what she has for us with regard to this important topic. Welcome, Sabelo.
Thank you very much, Madam Moderator. The talking points of today's presentation are one, that we're going to demonstrate effective leadership behaviors that promote calm, coordination, and clear direction during high-pressure clinical situations, such as resuscitation, trauma, or in medical emergencies.
Are you there? Did we lose you? Hello?
Hello, we are here.
Yes, we are listening.
Did we lose Sabelo, the presenter?
I think we have lost her. We can't hear her.
Yeah.
Apply principles of teamwork and disciplinary coordination. Physicians and nurses.
She's here.
Okay, let us all mute. Sabelo, you can continue. We had lost you. I can't hear her again. Can you hear her?
No.
No.
Okay.
Must be experiencing some network issues.
Yes, we are going to reach to her. Rutendo, are you there?
They are together, so they must be experiencing the same network issues.
Yeah. Let me see through the secretariat if we can reach them. Please bear with
Hello.
us. Just
yes, Dr. Damaris.
we cannot hear Sabelo.
Okay, I'm just
We
checking
lost
here
her.
on the list. Sabelo. I think it is a network issue because Sabelo is not there.
And
No, she's used. I think they're connected using Rutendo's PC.
Okay, let me just check her via WhatsApp. and then I'm getting back.
Okay, thank you, Julius. Okay, she's rejoining. She had lost network.
All right, thank you.
Okay, as she rejoins, I've been going through the charts, and most of our comments are actually.
Madam Moderator,
are you back?
I'm back. Sorry for that. I don't know what happened. That's that, yes.
Okay, sorry,
Yeah,
you can continue.
Thank you very much. So I was talking about the third, which is structured utilization of structured communications frameworks, such as the SBAR, closed loop communication, is to enhance accuracy, clarity, and efficiency in the exchange of critical information under pressure. And this also helps us with the interventions when we are using situational awareness and evidence-based frameworks, like the ABCDE and the rapid triage models, like it has already been talked about by the other presenters. The fourth objective is to evaluate decision-making processes and prioritize patient care through debriefing and reflection. Also, reflect on the emotional and psychological aspects of crisis leadership. So this can be done through fostering resilience, mutual support, and psychological safety within high-performing healthcare teams. Next slide, please. Next slide, please. Okay. When we are talking about leadership, teamwork, and communication in high pressure situations, we are supposed to remember that with leadership should be decisive, it should be clear, and there should be emotional intelligence. In terms of teamwork, there should be collaboration, and the team should be trusting and also adaptable. Then when we are talking about communication, communication should be clear, concise, and open. And we are going to see as I go on with the presentation how we can attain this, because when these three elements are put together, they work to enhance performance, there is reduction of errors, and it builds resilience in high pressure environments. So nurses, we've heard that they serve as leaders and they are coordinators and communicators in critical settings. So in high pressure situations such as trauma, resuscitation, or in a medical emergency, nurses often take the lead in mobilizing the team. Since that effective collaboration really determines the survival of patients in the first 60 minutes. So nurses translate strategy into action by coordinating between the emergency, ICU, theater, and they support under high pressure situations. They do this by ensuring that there is rapid assessment, prioritization, and communication. And these were talked about in detail by Rutendo in first presentation. So nurses also advocate for patients and they maintain this situational analysis, which is extremely important when we are under high pressure situations. So these nurses act like connective tissue. Just like connective tissue, nurses support and bind the healthcare team. Next slide, please. When we are talking about communication, leadership and decision making. So leadership under pressure requires a leader to be composed, to be clear, and also to have confidence so that the team members can see that this person who is leading us really knows what they are doing. So the communication should be clear, like I said, it should be concise, and they should be confirmed communication, because confirmed communication improves survival rates of our patients, it reduces complications, and can therefore lead to better outcomes and quality of life of the patients. So when we are talking about the frameworks like the ABCD and the SBA, and also when we talk about the closed loop communication, which Rutendo talked about, the closed loop communication, I will not delve so much into the ABCDE and SBA because they've really been explained in the first presentation. So the closed loop communication in high pressure situations in terms of teamwork, they need someone to have clarity. So the person who is giving the information should be very clear. And the person who is receiving the information should repeat what the sender, the message that the sender had given. And then the communicator should agree with what the receiver is saying, so that there is this raw clarity. So teams can also improve their performance, they can reduce errors, and enhance patient safety in high pressure situations if we use this closed loop communication. When we are talking about psychological psychological safety. So psychological safety increases team collaboration. It improves team collaboration, improves decision making. It also encourages learning and growth, leading to better problem solving, increased team engagement, and a reduction of errors by fostering psychological safety. The teams that can create an environment where all voices are heard, valued, and respected. The next. So when we are talking about the resilient, just go back, Madam Moderator, sorry.
Sorry, next slide.
Okay, so I was talking about leadership. I'm just emphasizing that leadership is about clarity and it is not about rank. So when we are in a high pressure situation, we are supposed to know that when you are a leader, we are not supposed to bring our titles from work, like I'm the chief nursing officer, I'm the principal nursing officer. There in the high pressure situation, you are leading there, or anybody who takes up that leadership role is supposed to be allowed to take up the leadership role. And we allow that person to actually lead and not look at the rank of the person. Okay, yes. So when we are talking about building resilient teams and the closing reflections, we are really talking about simulation and mentorship. And we are supposed to remember that these foster confidence So how does these two foster confidence? So simulation and mentorship are powerful tools for building confidence in high pressure environments. So when you are doing a simulation, this simulation can actually mimic a high pressure environment. This would help the individual to prepare for real world challenges. Also, in terms of mentorship, mentors guide, they support, and the feedback is there to help the individual to build confidence. So when there is stimulation and mentorship in our nurses, this will foster confidence because they would have had the skills, they would have acquired the skills, the competencies, and the confidence to perform when under high pressure. Also, leadership cultivates trust and shared goals. So this leadership cultivates trust and shared goals when a leader is clear with what they are doing. By empowering the nurses, the healthcare system can actually tap into the expertise of these nurses. They can improve patient care, and it can also help to enhance overall healthcare in emergencies. So leadership really cultivates trust and shared goals, especially if the leader knows what they are doing, they are involving others, there is teamwork, and the leader is also reflective. You will find that the team which is being led will actually have trust. It also empowers nurses and strengthens healthcare systems, like I earlier alluded to. Next slide, please. So like we've seen in those two pictures, on the left-hand side, we've seen there is a nurse there mentoring another nurse. So this, like I said, builds confidence in the one who is being mentored. And when there is a high pressure situation, you'll find that this nurse will actually perform well. And on the right, these are simulations that are being done in Zambia. And we've seen how simulations and mentorship actually help the nurses to have confidence and they are able to perform when they are under pressure. Next slide. So when we are talking about the leadership, we are also supposed to know that there is also what we call crisis leadership. And I'm going to talk about some of the aspects of crisis leadership. So crisis leadership involves guiding and directing high pressure and uncertain situations. It also involves decisive decision-making, clear communication, emotional intelligence, and also adaptability. The strategies that can be used in crisis leadership include assessing, prioritizing, and these, ladies and gentlemen, we have seen that throughout the three speakers, they've really been emphasized. So these include assessing, prioritizing, communicating effectively. When these things are, when this is done in this manner, it empowers teams to delegate tasks, and it also empowers the members by helping them to maintain calm and focus during high pressure situations. How do they maintain this calm and focus? If the leader sets the tone for their team members, then the crisis leadership can reduce uncertainty, because clear leadership reduces anxiety and uncertainty, because the leader has shown that they know what they are doing. There is clarity of what they are doing, and it improves response because effective leadership enables teams to respond more efficiently, and also it enhances resilience through strong leadership. This actually helps teams navigate this crisis and recover. So we need to remember that emotional intelligence actually underpins effective crisis leadership. We also have to talk about the reflection after crisis. Reflection after crisis helps to process emotions. It also helps to learn and to prevent burnout, because when you reflect, it actually helps you to see where you're supposed to do things better, what happened, and things like that. So self-awareness is actually very important for peer support, and it sustains the leader's well-being and effectiveness. Next slide. To end my presentation on communication and teamwork, I like this Ubuntu philosophy, which talks about I am because we are, because there should be unity in action when we are talking about saving lives. So we may not always have equipment, but we always have each other. Therefore, teamwork is of utmost importance. Communication, leadership, these are important aspects when we are talking about high pressure situations. And remember that human factors are the most powerful tool that we have. Thank you very much for the opportunity.
Thank you very much.
Excellent.
Thank you very much, Sabelo, for that wonderful presentation. And I have carried with me your last statement where you have said we may not always have equipment, but we always have each other. Yes. That is very important in a crisis situation like we are talking about today. Mm-hmm. So our presentations end here. We have had the 3 speakers. And this session now we are opening for any questions. I will first go to the chat, and most of the chats here from the participants are basically just commending the presenters. And there are others who wanted to know whether they'll be able to get the presentations, the slides, after this session. And through the Secretariat, you will be able to get these presentations. Lemi will talk more about that, on how you can be able to access the presentation after this. And there was a question on, there was a question here that was asked by Chifundo Tamala. The question was, when providing positive pressure ventilation using bag and mask, how can you ensure that you are maintaining pressure of 20 centimeters of water? I can see Dr. Pamela has responded, but I'd like her to respond
Sure.
so that everyone else can be able to hear.
Sure. A lot of times we use another little tubing that goes to a manometer, and sometimes some of the warmers have the manometers on there. So that is something, an additional kind of advanced piece of equipment that you can use. What is most important, again, is using your eyes and watching for the chest rise. Those bags will not allow you to overinflate, but if you start pushing on that bag and you hear this popping off noise, that means that you are using the bag. Do you have too much pressure? What is the most important is to watch for a gentle chest rise.
Okay. Thank you very much for that response. Do we have any other questions? Anybody who has a question not put on the chat? Anybody? Yeah, I can see there's a hand raised. Kizito Kileu, please go ahead.
Yeah, thank you so much. First of all, I am Kizito, a registered nurse who is working in emergency department at FEM Hospital in Karatu, Tanzania, northern Tanzania. So first of all, I want to appreciate Dr. Pamela and the other presenter for awesome presentation. But for the case or for the purpose of knowledge sharing, I would really appreciate if we will have the system of sharing this slide so that we can share with our teams what we are learning in these webinars with the aim of improving healthcare and emergency care in ECSA region. Thank you so much.
Okay. Thank you, Kizito. Let me, can you respond to that on how the participants can be able to access the slides?
Yeah, thank you so much. And I'm sure we have the nurses and midwives who have been attending the webinars. The presentations are shared via iEcho in your page, and also the certificates. So you get the presentation and everything via your emails through iEcho platform. So as the way you get your email to remind you about the webinar, it's where you can go in and navigate and find the previous webinars, but also the presentation, and you receive your certificate via email. So everything will be shared through the platform.
Thank you.
Back to you, Madam.
Yes, thank you. Thank you very much, Kizito, and all the participants. You have been informed. You will all be able to access the presentations through your iEcho portal and even the certificate. And you can also access previous webinar presentations through the same portal. So thank you very much. Any other question? Okay. I can see there's no other question. At this point, I want to thank the speakers for very powerful presentations that they have given us. And I want to invite Lemmy to give a vote of thanks. Lemmy.
Thank you so much, Dr. Damaris. And I thank you all the colleagues who participated in this webinar. And let us share the knowledge that we have gained, the best practices, back to our workplaces. Let's not stay with this knowledge. It's very nice knowledge, well explained with the experts. And let's ensure that we provide ourselves the services timely, because we save lives as nurses and midwives. So the golden hour, very key. And let's save lives from the neonates, the newborn, and other departments that we save, perioperative, and all the departments. So thank you so much for attending, and big thanks to our speakers. They did a very great job. I'm sure we can all give them the flowers, the hearts, while we are saying bye to them. Thank you so much, and I wish you all a good afternoon, good evening, and let's work hard. Let's go back and disseminate the information. Let's change our ways of practice, because we are hearing new innovation, the best practices, and I'm sure we'll do that. Thank you, and bye all.
Thank you. Thank you very much as well.
Okay.
Thank you. Bye-bye.
Thank you too.
Okay,
Thank
bye.
you.
Thank
Okay.
you.
Bye.
Thank you so much.
Bye.
Thank you.
Thank you very much.
Thank you very much.
Tushazoma tayari huko tumeziteua. Siji. Kwa kweli.
Hizi ni za kwenu nyinyi?
Tumeziteua ziko mbili tu. Maana ndio blog party wanaomba tusaidie elimu. Kusafisha kwa maana kana vile
Kwa hiyo mnaziweka
hizi inakaa namba 2 nyuma. Huko sasa kika sisi wale sasa tunaandika. Kuna namba 2 kule wajua tunaweka kule. Kwa namba 5 wametugundua wameiba. Sasa hizo wamezifuta